My name's Scott Goldfarb, and I work with BeiGene. I'm a director there in our market access group, and I'm a pharmacist by training, and I have a master's in applied health economics and outcomes research. And what we did for this poster, we collaborated with the US Oncology Network, which is one of the largest oncology provider networks in the US across multiple states with one of the largest oncology populations in the US. And what we were interested in looking at was the use of BTKi inhibitors and whether there were any disparities on how patients were prescribed those across various socioeconomic factors. So whether they lived in rural or urban environments, their socioeconomic status based on the area deprivation index, essentially based on where they live, their zip code, and the type of payer they had, whether using Medicaid as an indicator of lower socioeconomic status. So there's now 3 BTKi inhibitors used for CLL, SLL, and it's just in the early days of research with having a third BTKi to market. As an observational researcher, we want to see if there's any types of channeling bias, if you will. Is there anything influencing whether or not a patient gets one medication versus another? Traditional, you look at comorbidities, age, sex, race, etc., performance status, but we wanted to add another layer on in terms of disparities. And again, looking at where the patient lived, their socioeconomic status. Essentially, what we found, we looked at all the CLL, SLL patients in the network that received a BTKi starting in January 20 through April 23. And we categorized them by which BTKi they received and whether they were switched from one BTKi to another within that time frame as well. We found there was a temporal trend. Of course, over from 2020 to 2023, we saw a decreased utilization of ibrutinib, the first generation BTKi, and over that time through 2023, an increased use of the second generation BTKis, acalabrutinib and zanubrutinib. As you might suspect, the newer agents showing more efficacy and better tolerability, being used more over time, which is a good trend to see from a patient perspective. The second thing we looked at, of course, were there any disparities in how those were prescribed, and we didn't see any disparities. So whether a patient lived rural or urban, whether they were in a disadvantaged area based on zip code or not, or whether or not they received Medicaid, they were all equally as likely to receive any one of the treatment options. So we found that comforting. So from a researcher perspective, it adds a layer onto do we need to adjust for this like we would adjust for comorbidities? Probably not, but it's a nice variable to keep collecting. Secondly, it was a good quality check, if you will, from a provider, large provider group perspective. If they would see a disparity one way or another, it would be good information for them to react to if needed.